Welcome, everyone. Welcome. Good afternoon, everyone. Great to see all of you joining us for this seminar, the last seminar for this year. I'm just going to give it a couple more minutes to let people in, and then we can get started. Welcome, everyone. Wonderful to have you all joining today. It's a busy day today, I can see. Welcome, everyone. We're just going to give it a couple of minutes. Just reminding everyone that this seminar is recorded. It's been recorded. Welcome. Welcome, everyone. Welcome to the seminar in aging. Welcome, everyone. We're just about to get started. We're just giving it a few more minutes to get people settled. If you're having your lunch or you're just listening to us, welcome, everyone. Wonderful. I think we can probably get started. So just reminding everyone that this session is being recorded. Good afternoon. My name is Pazit Levenger. I'm a senior principal researcher from the National Aging Research Institute, and I'm going to be your chair for today's sessions. Before we introduce our speaker, I just want to begin acknowledging the traditional owners of the land on which we are meeting today. For me, that is the Wurundjeri people. I would also like to acknowledge the traditional owners of the lands and water across Australia. And I pay my respects to elder past and present and to all Aboriginal and Torres Strait Island people, including members of the Stolen Generation. So just before I introduce you our lovely speaker, I just want to go through a housekeeping for today. So reminding everyone that the session is being recorded. And if you have any questions that come through during the presentation, please use the top options for the Q&A. So just write your questions over there. It's the little bubbles in the top, middle top. You will be given the option if you want to raise your hand at the end to ask questions. We can unmute you and you can ask your questions, but I'm just reminding you that it's all being recorded, so just be mindful. This is the last seminar for this year, and we will resume again in 2026 in February. So let me just introduce you our speaker for today. So today we'll be hearing from Dr. Anoohya Gandham. She's a Postdoctoral Research Fellow in the Bone Health and Fracture Research Program at the MacKillop Institute for Health Research at the Australian Catholic University. She completed her PhD through Monash University, where her research investigated body composition and musculoskeletal health in older adults with obesity and sarcopenia. She's a qualified densitometry technician with extensive experience operating in DEXA machine, and also peripheral and high-resolution quantitative computed tomography. Dr. Grantham research primarily examines muscle-bone relationship in aging, with particular interest in sarcopenia, obesity, and sarcopenic obesity, and how these conditions influence the risk of falls, fracture, and disability among older people. So today she will be presenting insights into the muscle and bone quality in postmenopausal women. All right, Anoohya, over to you. I'm just going to mute myself and feel free to start.
Awesome, thank you. Hello, everyone. Thank you, Pazit, and thank you, Nari, for the opportunity and for the warm welcome and introduction. So before I go into my talk today, I just thought I'll just give you a quick sort of introduction about me. So I completed my PhD from Monash University in 2022, and ever since, sort of my work has primarily focused on musculoskeletal health in older adults. So I believe that strong muscles and bones are sort of the foundation for healthy, independent lives as we age. So just imagine your grandmother struggling to get up from a chair or tripping on just a very small step. How fearful is that? Strong muscles and bones aren't just about numbers. on a scan. They're what allows her to stay independent, move safely, and live life on her own terms. So today, I'll be sharing some insights into muscle and bone health and quality in postmenopausal women and why this area is so important for understanding healthy aging. So I'm going to start off by giving a brief background on age-related muscle and bone loss and why understanding this sort of muscle and bone relationship is important, especially in postmenopausal women. I'll then introduce the importance of evaluating bone microarchitecture using advanced imaging modalities. And then I'll sort of summarize two studies. So the first study will just sort of explore how muscle mass and strength relates to bone microarchitecture. And study two sort of will focus on muscle quality and quantity determined from advanced imaging modalities and how that's linked to bone outcomes and bone microarchitecture. I'll then sort of wrap up and bring the findings together to show the consistent evidence across both studies, supporting that there are strong muscle-bone interactions in this population. So let me start off with some background. As we age, both muscle and bone gradually decline. And together, these changes sort of contribute to increasing frailty and fracture risk. One of the key age-related conditions is known as sarcopenia. It is defined as the loss of muscle mass, strength, and sort of physical function. Now, as you can see the image on the slide, there is sort of a clear difference between healthy muscle and among those with sarcopenia. You can see that among individuals with sarcopenia, there's a much higher proportion of fatty tissue and a very small proportion of muscle and overall bone. Now, the problem is that this decline in muscle sort of occurs alongside changes in bone. And osteoporosis is another common condition among the aging population. Now, when we compare normal bone with osteoporotic bone, we see that osteoporosis involves not only reduced bone mass, but also deterioration of the bone's internal microarchitecture. Healthy bones tend to have this sort of nicely dense, well-connected trabecular network, whereas osteoporotic bones show this thinning or have this increased porosity and weaker structural integrity. Now, functionally, these changes in bone and muscle sort of have these major consequences. So reduced muscle strength and reduced overall balance increases the risk of falls, while weaker bones sort of elevate the fracture risk from even minor falls. And particularly when sarcopenia and osteoporosis occur together, as they often do among older adults, the combined impact significantly increases frailty, functional decline, loss of independence, and hospitalization. Therefore, understanding the link between muscle and bone isn't just academic. It could mean that the difference between independence and reliance in later life. So although these processes sort of begin in midlife, they tend to accelerate after menopause. And this is largely driven by the sharp decline in estrogen, which sort of affects both the muscle and the bone. So let's start off by looking at this image. This basically shows how bone mass sort of changes across a woman's life. Bone tends to grow steadily throughout childhood and adolescence, and then it peaks in early adulthood, and then it slowly declines. But after menopause, it's not just a slow drift, rather, it's sort of a steep cliff. And now a major reason for this accelerated decline is the estrogen deficiency. When estrogen levels fall after menopause, bone resorption increases while bone formation becomes impaired. Now, this imbalance is what leads to a rapid loss of bone strength. But estrogen doesn't just influence bone, it's also essential for maintaining healthy muscle. Reduced estrogen sort of lowers this muscle protein synthesis and contributes to poor muscle quality, making postmenopausal women more vulnerable to sarcopenia, which in turn has important implications for this muscle-bone relationship. Now, as we are all aware, muscle and bone don't just function in isolation. They're deeply interconnected both functionally and biologically. Traditionally, we've sort of explained the connection between the muscle and bone through mechanical loading. So, meaning that strong muscles have this pull on bones, keeping them strong. But the simultaneous decline of both tissues after menopause tells us that there's more at play. It could be the shared hormonal pathways, the metabolic pathways, or the inflammatory pathways, which are all sort of influencing muscle and bone in parallel. Therefore, understanding these connections is crucial. Now, with recent advancements, we have these tools that can measure both muscle and bone with great precision. We can identify changes early, intervene strategically, and help women maintain strength, mobility, independence far longer than previously thought. DEXA is one of the most widely used tools in both clinical practice and research. One, because it's quick, accessible, involves very low radiation, and is also because it's highly validated. It is considered the current gold standard for assessing bone density. DEXA provides aerial bone mineral density expressed in grams per square centimeter. It's also the primary method used to diagnose osteoporosis and to monitor its treatment over time. In addition, it can measure BMD at sort of key skeletal sites, and this includes total hip, femoral neck, and lumbar spine. So these are sort of areas most prone to fractures with age. Now, however, despite its strengths, DEXA does have some important limitations. Because it's a two-dimensional imaging technique, it cannot really visualize bone microarchitecture, and it does not have the ability to distinguish between the cortical and the trabecular compartments. Now, this kind of limits our ability to fully understand the structural changes that occur with aging or diseases. And in addition, another limitation is that DEXA measurements can be affected by body size, which may sort of influence interpretation in some populations. Now, in addition to BMD, though, DEXA from the whole body scan is also utilized to assess body composition, including lean mass, which sort of makes it a valuable tool for identifying low muscle mass in conditions such as sarcopenia. It sort of provides the total and regional lean mass values, and from these, we can sort of calculate the appendicular lean mass index, which is commonly used in the diagnosis of low muscle mass and sarcopenia. While DEXA gives us this useful information on the overall bone density and lean mass, the problem is that it doesn't always allow us to examine bone or muscle in greater structural detail. Now, this is where the high-resolution pQCT imaging modality comes into play. So we're very fortunate to have access to this machine at the Australian Catholic University. Now, this imaging modality is an advanced 3D imaging technique that allows us to assess bone and the adjacent soft tissues at a microstructural level. So this machine gives us a much more precise evaluation of bone strength and quality than the conventional methods. One of the major advantages is the ability to distinguish between cortical, which is the outer shell of the bone, and the trabecular, which is sort of what I refer to as the inner mesh of the bone. If you have a look at the image that has just come up, this machine sort of allows us to quantify various parameters, including cortical thickness, porosity, density, as well as measure trabecular number, thickness, and volumetric bone mineral density. So overall, this high-resolution pQCT scanner provides a comprehensive view of bone microarchitecture, making it a powerful tool for research and for understanding bone health in postmenopausal women. HR-pQCT allows us to measure bone microarchitecture at two key sites. So the standard site, located near the joint, as well as the 30% site, which is located further up in the shaft. These measurements sort of provide detailed insights into both the trabecular and cortical bone, helping us understand changes with age. Now, in this figure, we are comparing HR-pQCT scans of females across two age groups. So young adults aged between 18 to 20 years, representing sort of this peak bone mass, and older adults who are aged between 75 to 80 years, representing the aging bone. Now, the top two rows sort of show the distal radius and distal tibia, which are part of the standard site. Within this image, or these images, you can see that the green network represents the trabecular bone, which is sort of spongy and metabolically active, while the thin gray line sort of represents the thin cortical shell. Now, if I may redirect your attention to looking at the images of the 18 to 20-year-olds in the left column, we can see a dense and full green trabecular network in the distal sides. Now, this sort of represents the healthy peak bone mass. Now, the cortical shell in the diaphysis sides, so the 30% sides, appears solid and non-porous, as expected. Now, in contrast, though, in the older adults, we notice significant changes. Particularly at the distal tibia side, there is sort of this large empty void in the center, indicating that much of the trabecular bone has been lost. And at the diaphysis side, the cortical rings sort of appear porous, reflecting this age-related cortical thinning and increased bone brittleness. So overall, these HR-pQCT images visually demonstrate how both the trabecular and cortical bone tend to deteriorate with age, highlighting the importance of assessing bone health in postmenopausal women. Now, although this high-resolution pQCT scanner was primarily developed for high-resolution bone imaging, it also sort of captures detailed images of the surrounding soft tissues. Now, this feature allows us to assess local muscle characteristics at peripheral sites, such as the tibia and the radius at the 30% site. Now, unlike DEXA, which mainly sort of provides lean mass, as I mentioned before, HR-pQCT gives us insights into both muscle quantity and quality. Some of the key parameters that can be measured include muscle volume, which sort of reflects muscle size at the scan site, as well as muscle density, which indicates muscle quality. So just to put it into a little bit of context for you, lower density values tend to suggest that higher fat infiltration occurs. In addition to this, HR-pQCT can also estimate the intramuscular fat content through the soft tissue attenuation. So this sort of gives us a more detailed picture of the muscle composition than what the DEXA can offer us. So overall, this capability makes HR-pQCT a valuable tool for sort of simultaneously studying bone and muscle health, particularly in postmenopausal women, where both tissues are sort of vulnerable to age-related declines. Now, while this high-resolution pQCT scanner provides this high-detailed insights into both the bone and muscle structure, there are still sort of important limitations and gaps in the research. Firstly, long-term data are lacking. So there are very few longitudinal studies that have sort of tracked how bone microarchitecture as well as muscle parameters change across menopause or with aging. So we still fully do not understand how structural deterioration progresses over a period of time. There are also limited intervention studies. We do not yet know how sort of interventions such as exercise, nutrition, or novel therapies, including probiotics or prebiotics, affect these HR-pQCT-derived bone or muscle outcomes. Notably, response patterns may differ from those observed using DEXA, meaning that findings from DEXA studies may not fully translate across, and hence the need for further research in this space. And finally, the muscle parameters determined by this HR-pQCT scanner are underexplored. Parameters such as muscle density, volume, fat infiltration have not really been widely studied, especially in postmenopausal women, and their clinical relevance, for example, in predicting falls or fracture risk, is still emerging. Overall, while HR-pQCT offers these unique insights, more longitudinal and interventional studies are needed to fully understand its value for musculoskeletal health in postmenopausal women. So, when we come to the bone-muscle relationship, particularly at the microarchitectural level, it is unfortunately poorly characterized at the moment. Although HR-pQCT allows the simultaneous assessment of adjacent cortical and trabecular bone and the surrounding muscle tissue, few studies have only examined how these microarchitectural features, including the trabecular morphology or the cortical volumetric bone mineral density or the cortical porosity, are linked to muscle quality and quantity, particularly in postmenopausal women. So as a result, the extent to which bone and muscle influence each other structurally and functionally remains sort of uncertain and unclear. Now, to help fill these gaps, so we have conducted our first study, and this study is titled Associations Between Muscle Mass and Strength and Bone Microarchitecture in Caucasian Women. Now, this study has been recently published in Osteoporosis International. So the aim of this study was to investigate how muscle mass, as well as muscle strength, determined by hand grip strength, related to bone microarchitecture in 160 postmenopausal women participating in the ongoing OsteoPrep study, currently running at the Australian Catholic University. Now, I'm not going to go into too many details about the methodology for this study, as this has been published and is accessible online for those interested. But I am going to take you through some of the key findings from the study. So from these results, we did observe that higher appendicular lean mass index was associated with larger cortical bone area and greater trabecular volumetric bone mineral density, determined by the high resolution pQCT scanner. So this kind of suggests that women with more muscle mass tend to have stronger, better structured bone, particularly at the trabecular level. Now, a similar pattern was sort of seen with muscle strength, as hand grip strength was correlated with larger cortical area, and this was observed at both the radius and the tibia, which indicated that both the muscle mass and muscle strength contributed positively to cortical bone size. However, there was an interesting nuance in these findings. Higher appendicular lean mass index was also associated with lower cortical volumetric bone mineral density. Now, a possible explanation for this is that it may be due to a reflect of a trade-off, where the greater muscle mass leads to sort of bigger bones, but potentially this comes at a cost of slightly lower cortical density, suggesting that the bone may adapt more in size than in density. In this study, we sort of also investigated the role of physical activity, which was measured in metabolic equivalent hours per week, obtained from the accelerometer data. And we found that physical activity partially mediated the negative association between appendicular lean mass index and cortical volumetric bone mineral density. So this finding sort of highlighted that mechanical loading and physical activity levels, in fact, tend to influence how muscle mass relates to cortical density. So overall, these findings indicated that muscle mass and strength are consistently linked with bone size and trabecular density in postmenopausal women. But the relationships are complex. Factors such as physical activity and cortical density patterns add important context to understanding how muscle and bone interact in this population of older women. So in our study one, we examined how the traditional indicators of muscle health, such as lean mass and grip strength related to bone microarchitecture. And that work demonstrated clear links between muscle mass, muscle strength, and bone microarchitecture in postmenopausal women. Now, in this second study, we aim to build on to those findings by using the high-resolution pQCT scanner to capture more detailed measures of muscle quantity as well as muscle quality. As I've already mentioned, unlike DEXA, which primarily sort of provides lean mass, HR-pQCT scanner allows us to assess both the size of the muscle compartment and its density as well, offering insights into the overall muscle composition beyond simple muscle mass. Now, by combining these advanced muscle and bone measures, our goal was to determine whether muscle quantity and quality were associated with the underlying bone microarchitecture in postmenopausal women. Understanding these sort of, relationships helps us explore whether these refined muscle metrics may provide additional value for predicting skeletal health and fracture risk in this population. So this cross-sectional analysis is part of the OsteoPrep study, and it includes 160 postmenopausal women aged between 40 to 60 years. So the same population as utilized for study 1. We assessed muscle and bone health using high-resolution pQCT scanner, and particularly for muscle, we measured volume to capture the size as well as density to assess the quality at the 30% radius as well as the tibia, providing detailed insights into muscle composition. These measures were combined with bone microarchitecture parameters to explore how muscle characteristics related to bone structure in postmenopausal women. So now I'm going to be presenting you with some results. So this slide here shows the descriptive characteristics of the participants included in the study. Data have been presented as mean plus or minus standard deviation or as number percentage for categorical variables. Now, our study population consisted of postmenopausal women with an average age of about 56 years, a BMI of approximately 26 kilograms per meter squared, and an average body fat percentage of 39% determined by the DEXA. As you can see, only about 1% were current smokers. So this sort of reflects a generally healthy sample of older adults. Now, moving on, apologies in advance for this comprehensive slide, but this table here shows a linear regression analysis between the muscle parameters and bone microarchitecture parameters assessed by the HR-pQCT scanner. Data have been presented here as unstandardized beta coefficients with p-values. So as you can see, the bold values indicate statistical significance at p less than 0.05. Now, this analysis has been adjusted for confounders, including age, smoking status, time since menopause years, height, and self-reported physical activity. Just to put the results into context for you, the positive beta coefficients indicate that higher muscle volume or density is associated with higher bone measures, and the negative coefficients indicate the opposite. So just putting the data into a little bit more of a perspective for you, for each 1 cubic millimeter increase in muscle volume, there were measurable improvements in bone microarchitecture, as you can see. So for example, at the tibia, a 1 cubic millimeter increase in muscle volume was associated with higher trabecular bone density, thickness, greater trabecular number, meaning that the bone is denser and has more structural support among individuals with higher muscle volume. Now, similarly, each Hounsfield unit increase in muscle density, it sort of reflects that better muscle quality, which was also linked to stronger trabecular bone and higher volumetric bone mineral density. Interestingly, though, we saw that although cortical area increased, cortical volumetric bone mineral density decreased slightly with higher muscle volume at both the radius and the tibia. So suggesting this differential effects on cortical bone versus trabecular bone. These findings indicate that even small improvements in muscle size or quality can have sort of meaningful benefits for overall bone strength and bone measurement in postmenopausal women. Now, let us walk through the key findings from our study. Finding 1, the size advantage. Simply, bigger muscles are associated with bigger bones. Women with greater muscle volume tend to have larger bone size, which supports overall bone strength. Finding 2, sort of looking at the inner strength now. It's not just about the muscle sort of size. The inner mesh or the scaffolding of the bone, so I'm speaking about the trabecular network, is denser and more intact in women with higher muscle volume. Now, this happens because muscles don't just push the bone outwards. They sort of send these mechanical signals that help preserve the delicate internal structure, keeping the bone resilient from inside. Finding 3, which is what I like to refer to as the density paradox. Interestingly, while more muscle generally leads to sort of stronger bone microarchitecture, there's a slight trade-off in cortical volumetric bone mineral density. And as the bone sort of grows larger to accommodate the increased load from muscle, the mineral is spread over a bigger volume. So this can have slightly lower density of the cortical shell. Taken together as a whole, though, these findings highlight that it's not just about the amount of muscle that matters, but rather also the quality and the function of that muscle. So understanding this integrated muscle-bone relationship is therefore crucial when designing interventions to preserve musculoskeletal health and prevent fragility in aging women. While our findings are informative, there are several important limitations to consider. Firstly, the analysis was mainly cross-sectional in design, and the study population was limited to Caucasian postmenopausal women. So the findings may not be generalized to other populations, including other ethnic groups or men. And we also only assess specific HR-pQCT sites. Now, this is one of the limitations of the scanner itself. We were able to only assess the radius and the tibia. So the results may not represent these bone-muscle relationships at other skeletal sites, such as the hip, femoral neck, or lumbar spine. And finally, there is the possibility of sort of residual confounding. Now, even though we did adjust for factors including age, smoking status, time since menopause here, height, as well as physical activity, other influences such as diet, medications, or hormonal status could also impact muscle and bone outcomes, which need to be explored further. So you may be wondering what our next steps are for the study too. Firstly, as we all know, lifestyle matters. So we plan to include physical activity, nutrition, and other clinical factors to better understand how sort of these everyday behaviors influence this muscle-bone relationship in postmenopausal women. Next, we would also like to understand the metabolic connection. We want to explore whether these muscle parameters are linked with insulin or other metabolic markers such as glucose to see if part of the muscle-bone relationship is driven by metabolic pathways and not just by mechanical loading. Next, personally, I believe that timing is everything. So by examining further interactions with years since menopause, maybe we can determine if the time since menopause sort of modifies any of these associations, and whether menopause itself affects muscle and bone simultaneously. Finally, I think it's also important to consider sort of longitudinal studies. While this study utilized cross-sectional baseline data, as I mentioned previously, the OsteoPrep study is a longitudinal study that is currently ongoing. So following participants over time will allow us to see how maintaining or improving muscle quantity and quality impacts bone health. So we're able to move beyond the associations to explore this cause and effect and maybe come up with strategies to preserve musculoskeletal strength as women age. So ultimately, we do aim to connect the dots between lifestyle, metabolism, and menopause, with the goal of keeping muscle strong and bones resilient as women age. Now, just to look at the integrated findings across Study 1 and Study 2, we did find consistent evidence that muscle health is strongly linked to bone microarchitecture in postmenopausal women. So muscle quantity matters. Just to reiterate, women with higher lean mass, greater volume, and stronger grip strength all had larger cortical bone area and higher trabecular volumetric bone mineral density at both the radius and the tibia. So this suggests that having more muscle contributes to stronger and better structured bones. At the same time, muscle quality also matters. Muscle density was our marker of muscle quality, and even this parameter was positively associated with both the cortical and trabecular bone measures. So better quality muscle appears to support this sort of healthier bone microarchitecture. Interestingly, though, both the studies have showed sort of the same interesting pattern, where greater muscle mass or volume, it was linked with lower cortical volumetric bone mineral density. So as I mentioned, this is likely a normal mechanical adaptation. So more muscle leading to more loading on bones. And as we are all aware, bone responds by expanding outwards, so larger area, but becomes slightly less mineralized. So this trade-off effect helps bones stay strong while supporting higher loads. So as I mentioned, physical activity in Study 1 particularly explained that lower cortical volumetric bone mineral density, it sort of meant that active women with more muscle showed more bone remodeling. So just to highlight the overall message, muscle mass, muscle strength, and muscle quality all contribute to healthier bone structure and microarchitecture. Maintaining muscle in postmenopausal women through activity, strength, training, and preserving lean mass, whether it be through nutrition, it may be critical for maintaining bone strength and reducing the overall fracture risk in these postmenopausal women. Looking ahead, though, there are several key areas for future research. So expanding these studies to include non-Caucasian women will really improve generalizability, and particularly comparing premenopausal, perimenopausal, and postmenopausal cohorts could help us understand how the timing of menopause influences this muscle-bone relationship. So further interventional trials are also required. Now, particularly since we're seeing a lot of research among resistance training and the improvements or beneficial effects it has in this older group population, these programs should be tested to see their effects on both muscle and bone microarchitecture obtained from the HR-pQCT scanner. Nutritional strategies such as protein supplementation, vitamin D, calcium, and even novel approaches such as gut-targeted interventions, including probiotics and prebiotics, could also be further explored. Now, there is potential to combine exercise and diet interventions to achieve the synergistic benefits. So interventions should also look into this and evaluate the effects on bone microarchitecture and muscle parameters. So by tracking these longitudinal changes in muscle parameters, as well as bone microarchitecture over time, we can better identify the predictors of muscle and bone loss and fracture risk, and also can determine which interventions are most effective at preserving musculoskeletal health in aging women. So, in summary, our findings highlighted that muscle is bone's best ally. In postmenopausal women, preserving or increasing muscle mass and supporting muscle quality through physical activity, strength training, and nutrition may have sort of may meaningfully improve bone microarchitecture and reduce fracture risk. So by focusing on muscle, we have a practical and powerful way to protect skeletal health and enhance quality of life in aging women. So to close off, keep muscle strong and bones will follow. So finally, I would like to take the opportunity to thank our team at ACU and Pendulum Therapeutics for their support and contributions to the studies. Thank you all for listening, and I'm now happy to take any questions.
Thanks, Anoohya. That was quite comprehensive. Well done. If just to remind everyone, if you've got any questions, or you can raise your hand, use that function from the top window, or you can drop a question in the Q&A section on the top, and we're happy to then read the questions. I might just get started with some questions. I just noticed in your studies that you take into consideration a fair bit of factors, confounding factors. I just wonder what your thoughts around BMI, because and I noticed that some of your women there had relatively high percentage of body fat. And we know there's some interaction between, the heavier they are, you're more likely to also have some increase in BMD. So what are your thoughts around that?
Yep. Thank you for your question. So it's a great question. So particularly for this study, I believe that BMI and body fat tend to sit on the causal pathway between muscle and bone. So adjusting for either of those factors would sort of overcorrect and maybe even hide the true relationship. So which is why we sort of included height as one of the confounding variables and made an adjustment for that in our sort of analyses. But maybe I think, as you mentioned, since it's very closely related to all of these sort of tissues, maybe a further mediation analysis or sensitivity analysis might provide better information, understanding these underlying pathways. But yeah, thank you.
Thank you. Do we have any questions from anyone else? Anyone that want to raise their hand? I do have another one, but I don't want to take over. If anyone has any questions, please let us know. You mentioned in your presentation earlier the interaction and the impact of estrogen and what happens in peri and postmenopausal, but there was no indication or collecting any information from your group about the usage of HRT or anything equivalent to see if that has an effect. So what are your thoughts around that?
Yeah, thank you for your question. So with the OsteoPrep study, which is where we've used this data from, and I presented you the findings. So we did include women who were either osteopenic or healthy, and they had no other underlying conditions, and they were not on any HRT drugs as such, or any other medications that tend to influence the bone outcomes. So we just looked at fairly healthy postmenopausal women, which is why it kind of took us some time with recruitment, but yeah.
Okay, thank you. We've got a couple of questions. So Tracy asked if you're looking at differences in bone between women on HRT and those who are not.
Sorry, could you please repeat
There was
that
a question if you're looking at differences in bone between women on HRT and those who are
okay.
not, as a
Yep.
comparison with and
Yep, yep.
without.
Yep. Yeah, thank you for your question. So yeah, as I mentioned, no women were on any HRT as part of this study. So there's no way for us to look at it. But however, I think future research would benefit from that data as well. But yeah, particularly in this study, we could not do it.
Wonderful. Okay. And Muriel
Thanks.
asked the questions, who can request a, PQCT scan? Is it Medicare funded? I'm sure it's a very popular question. Is it available for people to use apart from DEXA?
Yeah, so that's a very good question again. Now, the problem with HR-pQCT scanner is that it is sort of mainly used for clinical research, and it cannot really use for certain populations because of the way or how sensitive this machine is. Now, to do a scan, you need to be quite still. When you put your hand into the gantry or your leg, you need to be quite still. So you can't really analyze the bone microarchitecture in all sorts of patients or in children, as a matter of fact. So that kind of limits our ability or our accessibility of the scanner. And in addition to that, so you cannot really get the scan through Medicare or get a referral from a GP. So currently still used for clinical research purposes, but maybe in the future with, advanced technology or like some beneficial gantry assistance, maybe we can extend this research to populations where, it is currently now difficult to do so, but maybe in the future it may not be as difficult.
And just on that particular topic, so we know then you mentioned in your presentation, DEXA is the gold standard in terms of, diagnosis of osteoporosis, osteopenia. So how far are we in terms of finding that, parallel, comparable, scores between, the high resolution option to the DEXA?
Yeah, that's a good question. I think there's still quite a bit of research needed in that space. I think it's still quite early on. Now, there may be sort of population-specific guides that we can use, but it cannot really be used extensively across all women at this stage, or study-related sort of specific guides. But yeah, I think there's still quite a bit of research needed for it to be standardized. And to be completely honest, DEXA scans are a little bit easier in terms of doing multi-center studies, as there's sort of these standardized protocols. But with the HR-pQCT scanner, it just makes it a little difficult, although there is more research and more standardization in terms of protocols, in terms of how the scans need to be done and performed so that, we can maintain this efficiency and share the data across all these centers. But yeah, still a couple of steps before we get there, I guess.
So we've got a couple of questions about exercise, but before I go to the exercise questions, I want to ask Jen's question. So Jen asks, thanks for your interesting presentation. As someone with osteoporosis well placed to benefits from interventions, your focus on modifiable factors is appreciated. I'm doing my best on the physical activity front. What's the latest on nutritional elements? Good question, Jen.
Excellent. Yeah, so in terms of nutritional sort of elements, I guess there's a little bit more and more data in terms of the effects of probiotics, prebiotics. So the symbiotics, which are the combination of prebiotics and probiotics, and their effect on overall bone health. So we do have these preclinical mice studies which have shown this relationship and some improvement up to a certain scale. But obviously, those studies were mainly conducted in mice. Now, this is why we are doing this study, this osteopip study at ACU. So we're looking at this longitudinal change where women are taking these symbiotic supplements over a period of 12 months, and we're evaluating how there are changes, if any, in muscle parameters, in bone parameters, metabolic health, and a wide range of cognitive, physical function. So hopefully at the end of the study, we're able to, provide you with some more information if symbiotics are the way to go, or if there's something that you could be taken in addition to calcium and vitamin D, as well as physical activity. However, there's quite a bit of research that needs to be conducted in this space before we can confirm any of these findings. Either if it may be beneficial to take them alone, but maybe if we combine them with exercise, there may be these added benefits. But again, further research needs to be done in this space.
So on the other end, so we know nutrition is very important, but nonetheless, exercise is as
Exactly.
equally crucial about that. So there are a couple of questions, and
Mhm.
Joanne Lee and Maslin asked around exercise. So one of them asked, what are the best ways to maintain muscle mass? Is it strength training or is there other activities that are required? And then Joanna, I wasn't sure if you had a specific question. Her comment was any specific questions about what type of exercise people were doing and for how long they've been doing in terms of impact. So what they can take, doing later in life.
Exactly. Yep. Perfect. Thank you. So there is quite a bit of research showing that you should ideally start exercise from a very young age, especially when you reach that peak bone mass. If you're constantly exercising at that time, your peak bone mass will obviously reach heights. And then there will be a little bit of leeway by the time you're aging, and then that decline during postmenopause occurs. So the best age to start exercising is when you're young. But yeah, obviously it is difficult to stick to exercise constantly, and there may be some limitations, whether it be access to facilities or time, things like that. Now, the current research sort of shows that high intensity resistance training program has sort of beneficial effects on improving muscle mass, and maybe taking it in combination with protein, making sure that you're having adequate protein intake could have beneficial effects on the overall musculoskeletal health. So the thing is that just because you haven't been exercising all your life, it does not mean that you can't start now. Even if you do it in moderation and just improve it and increase it step by step as you're going, you will see changes within yourself, whether it be, being more sort of physiologically stronger or having improvements in functional outcomes. You will notice them. But yeah, definitely strength training or high intensity resistance training is sort of the way to go, as research has been showing us lately.
Wonderful. And I think I want to, finish on a positive note. I'm coming from exercise background in my research, so it's never too late to start exercising, even though you have not exercised. You can get great
Exactly.
benefits at any age. You just need to start with
Exactly.
whatever you like, go from
Yep.
there. Resistance training is very important as we get older, with
Yep.
all what you've mentioned around the importance of keeping our muscles strong.
Yep.
Any other final comments from anyone before we wrap up for today? I want to thank our presenter for really, really wonderful and interesting presentation for today. It is recorded, so it will be available for people to view if they wish to watch it later. And also reminding everyone that this is the last presentation that we have for this year, but we hope to see everyone back in February 2026. And on that note, I hope you will have wonderful lunch. Thank you, Anoohya, for your time today. It was wonderful. Thanks,
Yeah.
everyone.
Thank you so much. Thank you for the opportunity.
Thanks, everyone. Take care now.